Bismillah ar-Rahman ar-Rahim. Treatment of mesothelioma and the outcome of mesothelioma. The treatment of mesothelioma include the following: management of pleural effusions. Early definitive treatment is the key, and repeated pleural aspirations should be avoided. Talc pleurodesis can be achieved either using a chest drain or at thoracoscopy, depending on local resources. Pleurodesis is not possible if the lung does not re-expand following drainage of pleural fluid, that's to say, trapped lung, and the resulting recurrent pleural effusions are difficult to manage. In that case, indwelling pleural catheters (IPCS) allows fluid drainage without needle aspiration and are useful in this situation. Primary use of indwelling pleural catheters is reasonable, dependent on patient preference. Second step of treatment of mesothelioma is radiotherapy. Routine prophylactic radiotherapy to procedure tracts is no longer recommended after two randomized controlled trials, SMART and PET, demonstrated no differences in rate of procedure tract metastasis. Pre and post surgical radiotherapy is also not recommended unless in the context of clinical trials. Palliative radiotherapy provides pain relief in proportion of patients with chest wall pain, including related to tract metastasis, but is less useful in the treatment of breathlessness or superior vena cava obstruction. The surgery. Five types of surgery have been used, which are extrapleural pneumonectomy, extended pleurectomy with decortication, lung sparing with complete macroscopic resection, including diaphragm, pericardium, if required, pleurectomy with decortication similar to extended pleurectomy with decortication, but no resection of the diaphragm and pericardium. Parietal pleurectomy or partial pleurectomy and thoracoscopy with pleurodesis, but their rules requires further investigation. Trimodal therapy, chemotherapy followed by extended pleurectomy with extrapleural pneumonectomy (EPP) and radiotherapy was evaluated in the Mars randomized feasibility study for resectable disease. Find the extended pleurectomy, extrapleural pneumonectomy group to have shortened survival without any gain in the quality of life, although the study has been controversial. Operative mortality is a 7 to 16% for extrapleural pneumonectomy and 4% for the PD, pleurectomy partial decortication. Mesovats randomized controlled trials comparing talc fluoridesis versus video assistant or video assisted thoracoscopic surgery. VATS partial pleurectomy showed similar overall survival at 1 year, but a significantly higher complication rate and length of hospital stay for surgery. Latest 2018 British Thoracic Society guidelines recommended not using partial pleurectomy over talc fluoridesis, not using extra pleural pneumonectomy, and not using the APD, which is extended pleurectomy with decortication, unless in the context of a clinical trial. And studies are ongoing, including comparison pleurectomy plus decortication with intra or end-wheeling pleural catheter, IPC. Systemic anti-cancer therapy. Patients with good performance status should be considered for chemotherapy. Pemetrexed, an inhibitor of DNA sensitive proteins, e.g., thymidylate synthase plus cisplatin, has an objective response rate tumor shrinking of more than 50% of 41% and conveys a survival advantage of just under 3 months when compared with cisplatin alone. Cisplatin pemetrexed combinations is a frequently used combination, although carboplatin may be substituted for cisplatin in those with an increased risk of toxicity. Addition of bevacizumab, which is a vascular endothelial growth factor inhibitor, to cisplatin pemetrexed, improves survival from median 16.1 to 18.8 months in one study with increased hypertensive and thrombotic complications. But this is not present licensed in United Kingdom. For this purpose, ongoing treatment of an individual may be guided by objective metabolic responses based on PET over CT. Other studies have shown that addition of ralitetrexid, although an inhibitor of thymidylate synthesis, to cisplatin improves survival by 2 months. General management. Early involvement of pain relief and palliatives can or palliative care service is required. Early improvement, early involvement of pain relief and palliative care service is required. Ensure adequate analgesia, opiates and nonsteroidal anti-inflammatory drugs for chest wall pain. Consider amitriptyline, pregabalin, pregabalin, and gabapentin for neuropathic pain from intercostal nerve or vertebral involvement. Nerve blockage or cordotomy may be required. Breathlessness may be multifactorial, e.g., pleural effusion and lung compression, wall restriction, pericardial involvement, anemias, pain and anxiety and fear. Discuss the compensation issue li- lays with general practitioner, specialist nurse, palliative care teams. Remind GP that all diseases have to be reported to the coroner. The Coroners Society of England and Wales and BTS have been encouraged coroners to avoid post request a coronial inquest inquest is opened and adjourned soon after this, but may take -3 months for full inquest compliance or full inquest to complete. Clinical course of mesothelioma, median survival 4 to 12 months from diagnosis, typically progresses by local extension, sometimes leading to involvement of the region by involvement of the contralateral line of the peritoneum, civic superior vena cava obstruction, cardiac tamponade, or spinal cord tamponade, or spinal cord compression, and distant metastases are common, 50% of autopsy, although occur late and rarely clinically apparent. That's all. Thank you.